I'm
I
with
will
you, sir.
give most of you nice cases. Don't worry. Okay. Okay. Go on.
So I'm
If you want to
presented
scroll.
with... no, sorry. Can you please scroll for me?
Okay.
Yes. So I'm presented with a contrast-enhanced CT of the abdomen within the axial cut. I'll scroll from the first to the last section, and then I will give my comment. Can you please go up, sir? Yes. Okay. Yes. So I'm noticing there is a soft tissue density. I think a mass lesion, or seen within the applied to the renal sinus, the right kidney renal sinus, with some internal vascularity within it, since this is the arterial enhanced space. I wasn't actually provided with the history of this patient, apart from
hematuria with right line pain.
Right line pain. So yes, there is this right-sided soft tissue collection or mass lesion within the internal vascularity within it.
Within the renal pelvis or renal sinus? Okay.
Within the renal sinus, yes.
Okay.
The left kidney appears to be unremarkable.
Okay, what do you think in this area at the left kidney? What is this one?
This is,
by the way, it is an incidental finding, but what do you think?
It is a fat density lesion, mostly angiomyolipoma.
Yeah. Yes, you are right. Okay, this is angiomyolipoma, cortical-based angiomyolipoma, and I think we have another one. I saw another one here. I don't know where is this one.
Yes.
Yeah. Okay. What else? In the right side, let's focus on the right side now. What about the contour? What about the contour of the right?
Yes, it is a contour deforming, actually.
Deforming.
I wasn't actually. I don't have the native studies to assess the post enhancement contrast, but it has a very it appears to be related to the renal artery, and it has a very an internal dot-like vascularity.
Okay, this is a venous phase.
This is the portal
nephrographic phase. Yes. Okay.
Okay. Yes, it's actually, I don't see the abnormality within. Yeah, this one. Yeah, this one. It appeared to be enhancing post-IV contrast. It's mostly within the, I think, mid to lower polar region of the right kidney.
Can you comment, please, on the renal parenchyma?
Renal parenchyma? The renal parenchyma appears to has a heterogeneous pattern of enhancement. There are
heterogeneous pattern of enhancement.
Wedge-shaped area of
hypo-enhancement. Very nice. Very nice. These wedge-shaped areas, I think, inside the renal parenchyma, hypoperfused, hypo-enhancing, and we have also cortical irregularity of the kidney. Okay, and as you said, there is something not clear inside the renal pelvis. Okay. Time. Can you please see the coronal delayed? I'm sorry to give it to you now. Okay. This is a coronal plane for the same patient.
There is all this confirmed the finding that there is this heterogeneously enhancing collection or mass lesion within the renal sinus, and also the wedge-shaped area of hypoperfusion within the right renal kidney, within the right renal parenchyma. I want to check the vascular contour, since this appeared to be irregular. I think it is related to a vascular injury, since I couldn't really appreciate the renal artery very well. And this hypoperfused area could be in keeping with infarction, or other possibility would be
stop here, please.
Most likely
you did very well. We have hypoperfused patch areas, wedge shape in configuration, either renal infarcts or
post-obstructive or pyelonephritis
or post-obstructive. Yeah, you are right. You did very well. You mentioned 3 main differential diagnoses at this point. Maybe post-obstructive, acute obstruction, maybe acute pyelonephritis, maybe renal infarcts. Okay, but I think how can we explain these filling defects inside the renal pelvis and calyceal group?
Yes, it is actually non-enhancing, and it's appeared to be
okay.
it's appeared to be of a soft tissue density.
Okay.
So I would put
Okay.
it's either a blood clot or
Yeah.
it
How
is
can we confirm is it blood clot or not?
By checking the Hounsfield unit.
In which part? In the delay or venous or corticomedullary or non-contrast phase?
Non-contrast
Which
phase.
phase? In non-contrast. Okay. Let's see the non-contrast.
Yes, so this filling defect appears to be hyperdense as compared
hyperdense
to the
very nice. It's slightly hyperdense. It is not hypodense. So most likely blood clot. Do you agree? Yeah. Okay. So we have non-enhancing filling defect, and the non-contrast study shows slightly high density of the filling defect. So most likely we have blood clot, and to be sure, short-term follow-up to see what is the progress of this filling defect. How can we link now the filling defect inside the renal pelvis, blood clot, with multiple wedge shape area? Which one is more logic now? Acute obstruction, acute pyelonephritis,
yes, acute yes, it's
or
most
renal
likely it's most likely due to acute obstruction. It is in this
acute obstruction
obstructive urinary
by this blood clot.
By this blood clot, yes.
What about the irregular outline of the renal cortex? Is obstruction
this one
will make something like this?
Yes, it's mostly due to chronic post-obstructive uropathy that would lead to parenchymal scarring.
What is the cause for blood clot? What is the cause for the blood clot for this one? How can we explain the cause for the blood clot? Is it logic to be renal infarct with blood clot, or acute obstruction secondary to blood clot? I think we don't have much calyceal dilatation inside the kidney. We don't have
it's not. It's just,
too much calyceal dilatation. I think prominence. I don't think that this one is post-obstructive sequelae. I think it's the most logic thinking, as you said in your differential diagnosis, renal infarcts with multiple wedge shape hypoperfused areas with filling defects inside the renal pelvis proved to be blood clot, and this one was proved to be multiple renal infarcts with blood clot. And the blood clot, by the way, is a common association with renal infarcts. Okay, if I diagnose this case renal infarct, what is the next step?
Could be a nuclear study.
You should search for the cause. Yeah, we should search for the cause. As you, I think I uploaded the standard FRCR approach video, that once we have any abnormal findings, you should search for any cause. What are the causes for renal infarcts? By the way, the inflammatory markers for this case, it's totally normal, and it was proved as a renal infarct. But really, what are the causes? What are the causes we should search for?
It's due to obstruction or occlusion of the renal artery by either.
Do you think the renal artery is it obstructed? Is it obstructed?
The distal, it's not actually, but
it's not obstructed. Not stenotic. Renal artery, one of the sites that you should check. Renal artery. Okay, what else?
Yes, there was like a periarterial soft tissue thickening and stuff, so I thought it must be renal artery stenosis
To
or
conclude
affection.
our case, we should any case of infarcts, splenic infarcts, renal infarcts, we should check the left side of the heart, ventricular aneurysm, any vegetations across these valves, the atrial appendage. Really, the atrial appendage does not appear here in our scan, but you should check the atrial appendage if it is present in our image. Also, you should check any aortic dissection, any aortic thrombosis, any aortic aneurysm, arterial. We should check the renal artery stenotic occlusion. We should check the renal vein in the venous phase. If there is any renal vein thrombosis, we don't have any renal vein thrombosis in this case. Also, we don't have any renal trauma. We should also check if there is any infarcts elsewhere, splenic infarcts, if there is any thromboembolism or something embolic filling defects elsewhere. All of this, you should keep it in your mind, okay? Also, I would like to add that if we have any subacute renal infarction, sometimes we have cortical rim sign, like capsular enhancement in subacute phase of the renal infarction. Yeah, but we don't have this sign in this case. Sometimes flip-flop enhancement, that means that the hypoperfused part in the venous phase, in the delayed phase or delayed venous phase, it will take contrast media. This one is called flip-flop enhancement. I think we did very well in this case. Thank you, candidate number 6. Let's go to our next case, candidate number 6 also.
Yes.
How are you, candidate number 6?
Good.
We have a nice case for you, candidate number 6.
Okay, thank you.
Okay?
Yeah.
Very nice case. Okay.
Okay.
Hematuria.
Yeah.
If you want to scroll, okay. If you want me to scroll.
Yeah, you can scroll, please.
Okay.
I have been presenting with CT in the delayed phase.
Yes.
Normal appearance of the pelvic calyceal system on both sides.
Yeah.
With normal caliber of the
yes.
ureter.
Yes.
Yeah, to go down with the ureter, please. Yeah, the right ureter seems to be obstructed at certain level and disappearing.
Right ureter?
And yeah, and it again began to be filling at the
I think this is a normal peristalsis of the ureter.
Okay. Yeah.
Normally the ureter can show non-opacified segments in between. Yeah. This is a normal peristalsis. Okay. Look for, I think, what about the urinary bladder? I think it's free. Do you think?
Yeah, it's distended, but I don't see any masses or abnormal enhancement within.
Yeah. Do you have do you have any abnormality, or do you pick, or did you catch any abnormalities that can explain the hematuria attacks of the patient? I think I didn't find any abnormality. I agree with you. Don't worry, okay?
Okay.
Let's go to see the coronal plane, because this case is a challenging case really. I am sorry to give you some challenging cases, but at the same time, I would like to give you some challenging and some straightforward case, okay?
Okay.
Okay.
Yeah. Is there like blunting of the calyx?
Yeah, agree. At the lower calyx? This one?
Yeah, I think, the lower one.
I think,
and I think also there was in the right one.
The fornices are slightly dilated. Okay.
Yeah, giving the W-shaped.
Yeah, okay.
Yeah, for that. Yeah. This could be within papillary necrosis.
Papillary necrosis.
Or like staging of TB. Having this.
Why did you think of papillary necrosis?
Because of the of the abnormal fornices one.
Okay.
Or it would be also medullary sponge kidney.
Medullary sponge kidney. How can we differentiate medullary sponge kidney?
Yeah, given the like brush appearance of the calyceal.
The brush appearance of the medulla of the kidneys, we don't have any brush appearance. Symmetrical, bilateral, we don't have.
Okay.
But
Yeah.
you are doing well, very well. But help me. I need help.
Yeah. And I think the left pole is enlarged. Like
Okay.
there's the left kidney lower pole.
Can you ignore the kidneys
Okay, just
for a while?
concentrate
Yeah.
on the calyceal.
Concentrate on the other findings.
Other finding other than the kidney?
Okay. Yeah. A part of the both kidneys.
Okay. Yeah, in this view.
Mm-hmm.
Is that H-shaped vertebra?
Yeah, you are right. Very nice.
Yeah. Okay.
Yes.
With sickle cell
You
anemia?
have here H-shaped vertebrae, H-shaped configuration of the lumbar vertebral column. Okay. What does it mean?
Yeah, it's like could be in the presentation of sickle cell anemia.
Sickle cell anemia. Very nice. So we have a case of sickle cell anemia. Okay. And sickle cell anemia with hematuria. What are the most logic differential diagnosis?
I think it could be infarction.
Okay. Yes. Can be vasculitis and renal infarction. Agree.
Yeah. Other causes?
Mm-hmm. Sickle cell anemia with hematuria.
Yeah. Yeah. I can't pick it.
You did. You mentioned at the beginning.
For the papillary necrosis?
Yeah, papillary necrosis, one of the common causes of hematuria in case of sickle cell anemia. Okay, what else? I will help you.
Okay.
RCC, renal cell carcinoma, we have different pathological types, either clear type, papillary, chromophobe, and medullary. Medullary
Yeah,
RCC.
medullary
Medullary
coming with
RCC,
sickle
it's
cell
a
anemia.
common, yeah, it's a common RCC in sickle cell anemia. Okay, but we don't have any filling defects inside the pelvic cell system. So RCC, it's far away. But we have maybe vasculitis infarction. We don't have any hyperperfused renal parenchymal areas, but we have here, as you said, calyceal planting. And what do we have more? Let's focus on the kidneys. What do you have on the left side?
Yeah, I think it's enlarged than the right.
What about the middle calyceal group on the left side?
Yeah. It's blunted and having...
What is this area?
Yeah, cyst-like. Yeah.
This contrast affiliation inside the medulla, very near to the calyx.
Yeah.
And also, I think we have here some blush or striation or streaks, contrast media beside the calyceal group. How can these abnormalities help you to suggest the diagnosis of papillary necrosis?
Yeah.
This is ball on T. Ball on T sign. Okay? Ball on T sign. Yeah, this is ball of T. I will show you some tips here because these signs are suggestive of papillary necrosis. These findings are suggestive of papillary necrosis. Let's go to my presentation. really renal papillary necrosis in patients with sickle anemia, it's easily missed. And we have multiple causes of papillary necrosis. We have mnemonic name, non-steroidal anti-inflammatory drug, N for non-steroidal anti-inflammatory drug, S for 16 anemia, A for analgesics, I for infection, D for diabetes and dehydration. Okay, so we have here 16 anemia. So we should think of renal papillary necrosis. And we have Gulf ball on T sign, like ball of the golf on the T. This is our sign. And we have from this side, CT is us. We have, this is a normal calyx and papilla. If we have the necrosis at the center, let's take this one. If we have a necrosis at the center of the medulla, so we will have ball on T. This is the ball on T, contrast circulation here on top of the calyceal group. This is a ball on T or egg on cup. But if we have papillary type of papillary necrosis, the fornices here is necrotic. If the fornices is necrotic at both sides, this is called lobster claw appearance. If the necrosis surrounding the whole necrotic papilla, this one is signet ring sign. It appears as a filling defect inside the calyceal group. And by the way, we mentioned this one in our differential diagnosis that we have filling defect inside the calyceal group. Papillary necrosis is considered one of these differential diagnosis. And by the end, it will be ended by calyceal blunting and calyceal dilatation. So this is the features of papillary necrosis. And let's go to our case. We have here ball on T sign.
Yeah.
It's a very early phase of papillary necrosis. And also we have some striation of the medulla beside the calyceal group. Really, it's not straightforward, but if we have any case of sickle anemia, we should
the print one, the print.
We should search for any signs suggestive papillary necrosis, and this one is considered as an early signs of papillary necrosis. Okay, suggestive. It's not diagnostic because we don't have a full picture, but we have features that can suggest early phase of papillary necrosis. Okay. Okay, I'm with you.
Yes, sir.
Okay,
so should I start?
Okay, what did you find?
Sir, I could appreciate, I'm provided with CT scan, non-contrast abdomen and pelvis images, and I could appreciate mild left-sided pleural effusion. In addition to that, I could appreciate significantly enlarged left kidney with surrounding perinephric fat stranding and simple air locules within the collecting system, within the renal parenchyma, extending in the perinephric fat as well.
Yeah.
Sir, so the right kidney, there's no gas within the right kidney. However, I could appreciate mild perinephric stranding on the right as well. So, so considering the imaging appearances, I'm thinking of emphysematous, left-sided pyelonephritis with stage 4 extension and stage 4 with extension into perinephric tissues as well. Okay, I'm totally agree. I totally agree with you that the left kidney is enlarged, swollen, and we have perinephric stranding. We have also thickening of the. I'm sorry. Can I take the please? Yes, sir. Yes, sir. Yes,
okay.
Sir,
can I control this one? Yeah, we have also thickening of the gyrota fascia, as you see here, and we have gas pockets, perinephric gas pockets, and also the gas pockets are seen within the renal parenchyma itself. And we have also heterogeneous appearance of the left kidney. And we have also some cystic fluid collection. Where it is located, this one? I think it is.
So I think it's anterior, anterior to left psoas muscle. Yeah, it is away located from the transverse abdominis muscle. It's just close to the psoas. I think it's intrapsoas abscess.
it's located as a posterior pararenal space. Okay.
Yes.
This one is a posterior pararenal space. Yeah. If we have collection here, it is anterior pararenal space. But if we have collection posterior to the renal fascia, this is the renal fascia. Okay, this is the renal fascia. If we have this collection, this is posterior pararenal space. So I agree with you that this is a case of emphysematous pyelonephritis. I think also the collection, I think is it severe form or severe or severe form of symptoms. Yeah. Okay. Let's go to next case. This is left side pain with hematuria also.
Sorry, sir. Can you repeat the history, please?
Left loin pain with hematuria.
Okay, sir, I'm provided with CT scan images. I could appreciate a fluid density structure and the left kidney interpolar region extending into perinephric space with thickening of the gyrotas and the zucocandal and lateral conal fascias with surrounding perinephric fat stranding. I could appreciate few calcific foci. Sir, I could appreciate there's a hyperdense. I'm not sure what is this. I think it is the collecting system that is hyperdense on the left. Yeah, this one.
I think, as you said, we have here cystic lesion.
Yeah, cystic with few calcific.
But yeah, apart from this cystic lesion, what do you have more? I think the calcium group, as you said, it's not dilated, but okay.
So
yeah.
There is a fat stranding and
fat stranding at the perinephric space.
I'm not sure, but these are these dilated vessels or what? These in the renal hilum. Hyperdense.
This one? This one hyperdense. Agree. Totally agree. Very nice. Very nice. Yes, you picked up very nice abnormality. We have something abnormal here, hyperdense at the renal sinus. What do you think is this one?
Can you move down, please? I think it's in the pelvic calyceal system. Because I think this
is... Do you think is this one inside the ureter?
So maybe. So can you scroll downward a bit? No, it's not. It's not. It's not.
It's not the ureter.
No, it's not the ureter. So, sir, is it? Can you put it with the gonadal vein as it is draining into the left renal vein?
It's draining into the left renal vein.
So,
very nice.
Yeah. So it might be thrombosed as it is significantly hyperdense.
Okay.
Or it may be enlarged due to this mass, and there would be some varicoceles inferiorly.
Okay.
But this scan is non-contrast basically. So
okay, this one. Sure. Okay, can we move to the contrast enhanced study?
Yes, sir.
Yes.
Yes, sir. Sir, on the contrast enhancement, yes, I could appreciate that there's a mass in the left kidney, and there is a extension. There is, I think, thrombus within the branches of the left renal vein, and I think in the gonadal vein as well, reaching up to the IVC. No thrombus in the IVC is
perfect. Okay, so again, if you see the non-contrast study, we have the left kidney is swollen with perinephric stranding and thickening of the fascia and minimal fluid collection at the pararenal space. And also we have hyperdense vascular structure at the left renal sinus. And this venous structure is continuous with the left renal vein. This is the left renal vein. So we have hyperdense structure, most likely gonadal vein. And this one is left gonadal vein on the left side, draining inside the left renal pelvis. It's hyperdense and suggestive of renal vein thrombose and gonadal vein thrombose. And really, when we injected contrast media, it appears hypodense, filling defects inside the left renal vein and gonadal vein. So we have a case of acute left side renal vein thrombose and gonadal vein thrombosis with secondary engorgement and swollen left kidney. Can you please comment what is the difference between the left kidney and right kidney regarding its enhancement?
Regarding
its enhancement.
Sir,
are the both kidneys similar in enhancement?
No, sir. The left one is hyper enhancing.
Yeah, very nice. We have persistent nephrogram.
Yes, sir.
The cortex and the medulla.
Yes, sir.
While here it is nephrographic phase. So we have persistent nephrogram, and this is a common association with renal vein thrombosis. Is the renal vein thrombosis considered one of the serious problem? What do you think?
Sir, I think so.
It's, yeah. What is the complication? What do you think the life-threatening complications?
Well, I
that
think it
can
there could be embolus and
pulmonary embolus. Yes, you are right. Very nice. Pulmonary emboli. If we have ovarian
Yes,
vein
sir.
thrombosis, gonadal vein thrombosis, renal vein thrombosis, IVC thrombosis, all of these are sources of pulmonary emboli. So you should take care, and you should announce, or you should inform the clinician as soon as possible. Okay, thank
Yes,
you
sir.
so much. Candidate number 8.
السلام عليكم دكتور. عفوا
وعليكم
دكتور.
السلام. Yes, yes.
عفوا دكتور إذا سمعت شو what is the cause of the renal vein thrombosis here, and what is this
really,
mass?
Really, this case is breast cancer receiving chemotherapy, and once we have malignancy, and also with chemotherapy, this is high risk of hypercoagulability status, and this case is venous thrombosis secondary to the malignancy status for the patient. We have different causes of vein thrombosis, either bland thrombus or tumoral thrombus. Bland thrombus means that we have non-enhancing phenotype. Okay, if we have malignant thrombus, it will appear as an enhancing phenotype. If we have renal tumor and invading the renal vein, it looks like an enhancing thrombus, malignant thrombus. But if it is not enhancing, as you see in this case, we have different causes like hypercoagulability status, pregnancy, dehydration. Sometimes we have some syndromes that can cause venous thrombosis. This one is considered as a bland thrombus, not malignant thrombus, and we have different causes for this one. And in this case, we have a breast cancer case. Okay. Thank you for adding this point. Let's move to next candidate. Candidate number.
Sir, can I ask a question, please?
Yeah. Yes.
So what was the cystic lesion in the left kidney?
This cystic lesion, it's incidental finding with peripheral calcifications.
It is?
It should be followed up. Yeah, it's simple cyst. It's simple cyst. It's not malignant cyst. Yeah.
Okay.
Yeah, we should apply Osniak classification to make this one. But we have really along the wall of the cyst, we have minute calcific foci. We should be, I think we don't have any internal septations or sick septations. We should apply our Bosniak classification. So this is an incidental finding. Okay. Let's go to the next candidate. Candidate number 10.
Yes, sir.
How are you?
Yes, sir. I'm fine.
Okay. Let's move by this case. Right side, right renal, right loin vein.
Okay, so I'm presented with CT scan abdomen, axial sections, post-contrast study in photovenous phase, nephrographic phase.
Yeah.
I can see that there are multiple hypodense wedge-shaped areas seen involving the right kidney.
Yes.
And there are also multiple rounded structures. I'd like to scroll.
Yes.
Scroll it once again for me. Thank you. Okay, so there is a large hypodensity noted in the upper pole as well in the renal parenchyma with marked adjacent perinephric fat stranding and thickening of the Girota's fascia.
Yes.
I'm looking at the vessels to look for the enhancement. The left renal vein is
what is
normal.
the sign, please? I'm sorry to disturb you, but what is the sign?
This is striated nephrogram.
Striated, yes. Striated nephrogram. Yes.
Striated nephrogram.
Striated nephrogram. Okay, that's good. What are your differential diagnoses?
My top differential diagnosis would be of pyelonephritis.
Okay.
Yeah, and this could be due to renal infarcts, could be due to renal vein thrombosis or any obstructive neuropathy.
Yeah, very nice. Okay. Those are the differential diagnosis of unilateral striated nephrogram. By the way, the case, I'm sorry, but this is a differential diagnosis of unilateral striated nephrogram. acute ureteric obstruction, acute pyelonephritis, acute renal vein thrombosis, also acute renal contusion, acute radiation of the kidney. This one is most important, okay? And also acute renal vein thrombosis causing renal infarcts, one of the top differential diagnosis, okay?
Okay.
Okay. Really, you should correlate this one with inflammatory markers and the clinical findings. This case had elevated inflammatory markers and was proved as acute pyelonephritis, okay? And should be also urine, we should do urine analysis, urine culture for the case to check this one.
This is CT scan.
This young lady presented with me, present for me, I think I reported this case 9 months ago, something like this, with acute hematoma. Really, to be honest, this is the only complaint that I had during my report.
Complaint of acute?
Acute hematuria. If you want to scroll, go on. If you want me to scroll for you, I will be happy if you want.
Yes, sir, you can scroll. Okay, I can see that here is, it is a CT scan, unenhanced study of abdomen axial sections, in which I can see that there is marked enlargement of the left kidney.
Yes.
And there are hyperdensities noted in the renal parenchyma, which are coarse. And there are yes, there are coarse calcifications, and marked enlargement in a hyperdense tubular structure is seen in the renal hilum. There is also perinephric fat stranding and thickening of the Girota's fascia. I like to see the coronal images if available. Because of the coarse calcifications and enlargement of the kidney and some hypodensities, my differential could include Xanthogranulomatous pyelonephritis.
Xanthogranulomatous, okay.
However, I like to see
I wanted to tell you before going to the non-contrast. I'm sorry to jump, but I need to review this case again. In the non-contrast study, where is the calyceal group of the kidney?
Yeah, sorry?
Where is the calyceal group? Can you comment on the calyceal group of the left kidney?
Yes,
is it dilated or not dilated?
There is deformity of the calyceal systems, and this is hyperdensity. These hyperdensities could be of concerning for any underlying hemorrhage or hematoma formation.
Yes, you are right, totally right. Okay, so this is the calyceal group, and this is the renal valves. All of these structures are distended with hyperdense element, maybe blood clot, maybe hemorrhagic insult. And we have, I don't know, is this one is calcifications or stones?
Yeah.
I'm not sure at this point. But I think when I start to report this case or I start to review this case, I thought that if this is a stone inside the calyceal group, I think this one can be inside the calyceal group or outside the calyceal group.
Yes, the peripheral one is outside the calyceal group.
Yeah, I think this one is outside the calyceal group. Yes, you are
right. It's in the renal parenchyma.
Really, when I started to ask the urologist at that time, he told me that the case is post-ESWL. Post-ESWL. Do you know what is ESWL? ESWL, extracorporeal shockwave.
Shockwave
lithotripsy. Yes. Yeah, for the renal stones. And this one, after the ESWL by 10 days. And as you said, we need to inject contrast media for the case, and we already inject contrast media for the case. And let me show you the contrast enhanced study. What do you think?
On the post-contrast study, I can see that there is a large perinephric hematoma seen on the lateral aspect of the left kidney, with internal areas of differential densities. And these calcifications are seen outside the renal parenchyma.
Very nice.
In this hematoma
in this
region.
area. Yes.
Yes.
Okay.
Yes. Yes.
Yeah. So do you think that these are calcifications or stones, according to the history?
Yes, and I want to see the renal contour is also not very clear at this level.
Okay.
The
Okay.
renal
Very
cortex
nice.
is
Okay.
also not very clear at this level, so it could be.
I'm sorry. I'm sorry. I want to ask you again. Are these stones or calcifications?
Stones.
Stones.
Calcific
Yeah,
stones. Yeah.
I agree with you. It looks like stones, and post as well shattered stones, small stones, fragmented stones.
Yes, yes.
Okay.
Fragmented
Okay.
stones.
Yeah. Yes.
Yes. And
What do you have more?
Sorry?
What else? Is there any more findings?
Yes.
You did very well.
Renal hilum once again, because I'm concerned about that dilated structure near the renal hilum. It's likely a dilated renal pelvis with some calcific density in this as well.
Yes.
Yes. So
I agree with you. This one is distended with hyperdense element, like looks like blood clot.
Yes.
Do you? Where is the renal contour? You said that we have irregular.
Yes. It
Is this the renal contour?
No, it's the perinephric hematoma.
It's subcapsular hematoma.
Subcapsular, yes, yes.
Yeah, this is the renal contour, and this is the capsule of the kidney. Yeah, this is the parenchyma of the kidney, and this is the capsule. This is the contour of the kidney.
Subcapsular region hematoma.
And this is subcapsular, large subcapsular hematoma,
causing
of different density. Effect. Yeah, and this is very large. Do you think that it may be as a complication of ESWL?
Yes, I think it's a complication of the procedure where some stones have reached out of the renal parenchyma in the subcapsular region, causing hematoma.
Yeah, I agree with you. Really, in this case, if you see this is a renal parenchyma and this is a renal parenchyma, at this area, the renal parenchyma, there is a defect in the renal parenchyma, and we have here the stones going outside the renal parenchyma into the subcapsular collection. This area, we have large subcapsular hematoma, huge subcapsular hematoma, and also we have intracalyceal blood content hematoma, and this hematoma causing obstruction of the renal pelvis and calyceal dilatation of the kidney. We have hydrolymphatic changes with blood clot inside. Let's see. So we are suspecting calyceal rupture. Do you agree with me?
Yes.
We decided to make a delayed phase for the case. Let's go to see the delayed phase. Really, we did delayed phase to search for any contrast extravasation for the kidneys. And really, we didn't find any contrast extravasation because the kidney itself, the kidney didn't excrete the contrast medium. Do you have any explanation? Really, we have calyceal rupture for sure as a complication of ESWL with large subcapsular hematoma, but the kidney didn't excrete the contrast media. Do you have any explanation?
It can be due to it's not excreting into the renal pelvis.
Yeah.
And
because
there is a large hemorrhage and hematoma in the region of
you are right.
renal pelvis.
Because we have something obstructing the renal pelvis, blood clot, acute blood clot, and this one is obstructing the kidney. So we have acute obstruction. So we don't have a good excretory capacity or function of the left kidney. I would like to ask you last question, please. If I tell you that the patient is hypertensive, not hypotensive, not hypovolemic, in spite of this large hematoma, the blood pressure either normal in blood pressure or high, slightly high pressure. Can you give me any explanation?
For
in spite of this large hematoma, the patient is not hypovolemic. No low pressure. Indeed, she had high pressure. She was young.
Because of the angiotensin converting enzyme mechanism to maintain blood pressure of the kidney. Yeah.
Did you hear before about beige kidney?
Yes.
Beige kidney means that if we have large subcapsular collection, it will compress the renal parenchyma. Yes, it will compress the renal parenchyma. The renal parenchyma became hypoperfused or becomes hypoperfused, and the renin angiotensin or the renin secretion, it will be activated. Renin angiotensin system will be activated, and it will elevate or it will raise the blood pressure. So the blood pressure can be normalized. So don't be mistaken by this point, because subcapsular hematoma can raise the blood pressure for these patients. Okay, in spite of this large subcapsular hematoma. Okay. Thank you so much. Really, yeah. This case, a young adult male patient complaining of hematuria.
Okay.
Okay.
Okay, I have been provided with the CT scan of the abdomen and the non-contrast CT scan of the abdomen. I can see that the left kidney is relatively enlarged. Actually, there is a hypodense mass lesion that involving mostly the upper pole of the left kidney, and I can also see some calcification areas within the mass. There is minimal perinephric fat stranding noted.
Okay.
The left adrenal gland is unremarkable. Actually, it is involving the mid and lower pole of the left kidney.
Yes.
And there is a dilatation of the left upper pole calyx.
Okay. Okay.
Okay. I would like to further confirm on the post-contrast study.
Okay. You have the post-contrast study.
Okay.
Okay.
This appears to be the arterial phase imaging.
Yes.
Okay. So there is a heterogeneously enhancing lesion involving the mid and lower pole of the left kidney, showing internal foci of calcification. I would actually there is mild perinephric fat stranding, but there is no involvement of the adjacent organs.
Okay. It is not invading the spleen or colonic flexure, colonic flexure, or it doesn't
artery
invade.
Appears unremarkable. I would like to see the renal vein in the venous phase.
Okay. Okay.
Okay. There is evidence of non-enhancement in the proximal part of the left renal vein. However, the rest of the renal vein appears normal.
Yes, agree. The main renal vein itself.
Yes, it is normal, but there is some area of non-enhancement in its part where it is, yes, where it is entering the kidney. Yes.
Yeah, adjacent to the mass lesion. Agree.
Yes, adjacent to the mass lesion.
Yes. Okay.
I would like to see the rest of the sections to see if there is any other lesion within the ureter or in the urinary bladder.
Yeah, you are right. Okay. We don't have any other lesions. We don't have any metastatic lesion. We don't have any polymetastatic lesions. So the abnormality is localized at the left kidney.
Yes. What is the, may I know the age of the patient?
The age of the patient is 39. Exactly.
39, okay.
Yes.
Based on these findings, it appears to be a renal cell carcinoma.
Okay.
With thrombosis of the peritumoral part of the left renal vein.
I think at the most adjacent part of the renal vein, but the main renal vein itself, it is not patent. Yeah, it's patent and normally enhancing with no filling effects. Okay. Okay, so we have a large expansile mass lesion involving the lower pole of the left kidney. or you can comment, or you can describe this one. You can describe by the site. The left lower pool of the kidney is expanded by virtue of large heterogeneously enhancing soft tissue mass lesion. And this mass lesion, I think, it invades the lower calyceal group, and also I think it shows small extension along the perinephric space.
Yes.
Look for this one. This is the Gerota fascia. And we have here small extension along the perinephric space. But as you said, it doesn't extend beyond the Gerota fascia. And also it doesn't invade the colon. It doesn't invade the spleen. It doesn't invade the pancreatic tail. Also, the most negative points, the adrenal gland is not involved. The main renal vein is still patent. It's very close to the renal artery branches here at the renal sinus. The mass lesion, we should measure the maximum diameter of the mass. Also, I would like to add something very important in any case of renal cell carcinoma, because this is Claw sign indicating that the mass is arising from the lower pool. But we have, if you wanted to describe the mass lesion, any mass in the kidney, we have 3 lines or 2 lines mainly. This one is superior polar line, and this one is the inferior polar line. It's present between the renal sinus. Okay, this is the renal sinus, the entry of the renal sinus. So we have 2 lines, and we have 3 spaces. This is upper pool, lower pool, and interpolar component. This mass lesion is localized at the lower pool and crossing the lower polar line to reach the interpolar component of the kidney. This localization is very important in case that we have nephron saving or partial nephrectomy, or if we want to decide if the partial nephrectomy is applicable or not. I am talking about the smaller lesion, not this one. This is very large mass lesion, but I'm talking how to localize the mass lesion. Okay. Just I would like to add something in my presentation. Very small tips. If we have any renal mass, we should do non-contrast scan. This is CT renal mass protocol. Corticomedullary phase, nephrographic phase. This one is very important to exclude any mass. If we have a small mass lesion, nephrographic phase is very important to exclude the renal focal lesion. Also, we should take corticomedullary, nephrographic, and exceptive phase to show the contrast uptake, the contrast washout of the mass lesion. Is it enhancing or not? What are the common types or pathological types for renal cell carcinoma? We have clear cell, chromophobe, papillary, medullary. Clear cell is highly enhancing and the most common type, as you see here in our case. Chromophobe, it's moderately enhancing. High papillary type is less enhancing, hypo-enhancing mass lesion. Medullary, it's common with sickle cell anemia. Also, we have 2 types of growth of renal cell carcinoma, either expansile or infiltrative. Expansile means ball shape. If we have, for example, this is a kidney, and this is a mass. This is ball shape, okay? This is the behavior of renal cell carcinoma and other solid mass lesions, oncocytoma and angiomyolipoma. We have another infiltrative growth. We have the mass, if it is start at the renal hyena or medullary portion of the kidney will be enlarged, diffusely enlarged, but it will keep the shape, the normal shape of the kidney, the pin shape, it will be maintained. This will be infiltrative growth, as you see in invasive transverse cell carcinoma and the minority of RCC as medullary carcinoma. I would like also to add something very important. If you, in case that you need to report a case of renal cell carcinoma, you should comment on perinephric fat invasion to the pelvic airway system, invasion to the renal sinus, adrenal gland involvement, vascular spread either to renal vein or IVC, lymph node should be, you should comment very clearly on lymph node spread, either soft tissue hepatic deposits or pulmonary dures or bony metastasis. Very common or very important this point in the exam. If you have a case of renal cell carcinoma, you should comment on the pancreas, either pancreatic mass or pancreatic cyst. You should comment even if it is negative in your exam to show the examiner that you are searching for von Hippel-Lindau. We don't have any pancreatic mass. We don't have any pancreatic cyst to support von Hippel-Lindau diagnosis. Either also lung cysts in case of Birt-Hug 2B syndrome. We don't have any lung cyst at the basis of the lung if you have CT abdomen exam. By the end of this session, this is the most important part, renal nephrometry score. Renal nephrometry score, you should comment the maximum diameter of the lesion. Is it below 4 centimeter or between 4 and 7 centimeter or more than 7 centimeter? Is the tumor exophytic, growing outside the renal contour of the kidney, or it is endophytic, invading the pelvic calyceal system? How far is the tumor from the pelvic calyceal system? Is it 2 millimeter, 5 millimeter? And how far from the renal sinus? The location of the tumor in the coronary plane, as we described, is it crossing the lower polar line or reaching the interpolar region of the kidney, or concise or confined only to the lower pool or upper pool of the kidney? The tumor location to the hilum, anteroposterior location, is it present in front of the hilum or posterior to the hilum? Also, if the case, in case of we have renal mass, is it touching the renal artery or vein or not? This is called renal nephrometry score. You should mention this one in your report. And I think I can number 12. Are you ready?
Yes, sir. Okay. Can I request, sir? I have requested for remote control.
Okay. Okay, go on.
Okay. This is contrast enhanced CT axial sections of abdomen and pelvis. I can appreciate that spleen is enlarged in size. The pancreas is displaced anteriorly due to the left renal parenchyma. It shows as compared to the normal right side, it shows relatively less uptake of contrast, and there are multiple calculi in the renal calyces. Also, I can appreciate that there is extensive perinephric fat stranding. Also, there are necrotic areas enhancing and the necrotic collections in the left perirenal space, and these are also extending along the posterolateral posterior abdominal wall.
Crossing the abdominal wall posteriorly.
Yeah, crossing the abdominal wall. There is also possible involvement of the left psoas muscle. The kidney is displaced by these enhancing collections. I am looking at the status of the renal vessels.
So as you described, this is a left renal vein. I think it is stretched, but it is opened. Yes, and as you said, the left kidney is markedly swollen, and we have dense branching stones within the kidney, and we have extensive perinephric stranding and cystic collections at the posterior pararenal space crossing the abdominal wall. What do you think is this one? I'm sorry, can you go more inferiorly? We have also, what about this renal sinus? What do you think?
So there is also a staghorn calculus in the main renal pelvis.
Yes,
and
staghorn, yes. Okay.
This is causing mild hydronephrosis. So I can put the fracture. My principal diagnosis in this case would be Xanthogranulomatous pyelonephritis.
Yes, you are right. Very nice. Okay, Xanthogranulomatous pyelonephritis, one of the common logic diagnosis here in this case. We have different densities. We have hypodense areas inside the kidney. We have hyperdense staghorn stone at this point. And we have also proliferation of the renal sinus fat.
Yeah.
And we have also posterior pararenal spaces, posterior pararenal abscess. So the most logic thinking that we have Xanthogranulomatous nephritis, and Xanthogranulomatous nephritis is characterized by lipid-laden macrophages or lipid-rich macrophages. Macrophages rich of lipid content. And if you know Xantho means, do you know what does it mean, Xantho? Xantho means yellow color, yellow fat color. So Xanthogranulomatous nephritis, it's granulomatous, chronic granulomatous infection with abundant fat content, as you see here, and the renal sinus. So this is a case of Xanthogranulomatous nephritis. Can you keep with me, please, candidate number 12, to see this case? This is last case that we have today. Okay.
Okay, in this non-enhanced CT axial sections, I can appreciate that there is fat-containing lesion involving the interpolar region of the kidney, and also there is extensive perinephric fat standing and high-density area in relation to this fat-containing lesion. Besides this, there was incidental note concomitant finding of simple cyst in the upper pole of the left kidney. There is also extensive perinephric and the Girota's fascia and lateral conal fascia. So if I can, this likely this is a case of angiomyolipoma, and it's rupture. So as this is emergency, I will pick up my phone and inform the referring physician or suggest referral to the interventional radiologist for urgent embolization. In this case, also after stabilization of the patient, I would like to see that the stigmata is association with this with the disease. If this is a case of tuberous sclerosis, I would like to see the heart for the rhabdomyosarcoma.
Yes. Very nice.
Also the lungs.
Very nice that you showed the examiner that you are searching for any association, any associated findings that support a case of tuberous sclerosis in case that we have angiomyolipoma. So as you said, we have here cortical-based mass lesion, and we have fatty density component inside the mass lesion, and we have perinephric hematoma along the anterior aspect of the lesion. So what's your final diagnosis in this case?
This is ruptured angiomyolipoma.
Ruptured angiomyolipoma or bleeding
hemorrhage.
Okay. Can you please tell me what is the borderline, or what is the size that is more susceptible to bleed?
I have no exactly
the cutoff value for the size of the angiomyolipoma. Which one? Do you know the cutoff value for the size?
I'm not sure. I think 4 centimeter, but I'm not sure.
Yeah, 4 centimeters. If we have angiomyolipoma more than or equal 4 centimeters, the high risk, there is a high risk of bleeding, more than 50% high risk of bleeding. If it is less than 4 centimeters, the risk of bleeding is between 10 and 15%. So 4 centimeters, it's highly suggestive to have high risk of bleeding angiomyolipoma. Okay, that's good. Thank you so much, candidate number 12. Thank you so much. I hope you enjoyed our session today. And if you want,
دكتور شكرا جزيلا. جزاك الله خير. دكتور المحاضرة روعة والله.
الله يكرمك حبيبي، ربنا يخليك. شكرا جزيلا
حبيبي. دكتور تنزلها على اليوتيوب هذه ان شاء الله المحاضرة.
I will record this one. It was recorded, and inshallah it will be divided into 2 parts, and inshallah it will be uploaded in our Easy Radiology Approach YouTube channel, and it will be free for all to watch this one. And if you have any comments, positive, negative comments, if you have any suggestions, I'm happy to hear from you, to modify ourselves, to be. I'm sorry to make this session very long, but really, alhamdulillah, I'm off duty today, so I have free time to sit with you.
جزاك الله خير. ميزان حسناتك ان شاء الله.
الله يكرمك. شكرا حبيبي، ميرسي جدا جدا، شكرا جزيلا. Thank you so much. Thank you. Bye-bye.